So thank you for this, is the mic working? So thank you for this opportunity to review key data in the treatment of cervical cancer. I'll focus today's talk on recent data in the treatment and management of recurrent and metastatic cervical cancer. My disclosures. So prior to just 5 years ago, the standard of care of FDA-approved approaches for the treatment of persistent, recurrent, or metastatic cervical cancer were combinations of platinum chemotherapies with radiation and biologic therapy, specifically anti-angiogenesis like bevacizumab. Over the last 4 years, since 2018, the landscape of systemic treatment in cervical cancer has rapidly evolved with the approval of immunotherapeutics like single-agent PD-1 inhibition pembrolizumab, as well as addition of PD-1 inhibitors in the frontline setting per Keynote 826. My focus of this talk will be these recent FDA approvals, and here I provide an outline of the topics of discussion for this presentation. So the rationale for immunotherapy. Upregulations in PD-L1 and L2 correlates with key immune cytolytic effectors. Here's cancer immunotherapies summarized in one slide. Recognition of cancers by the immune system begins with tumor lysis and release of tumor antigens. These antigens or proteins get taken up by antigen-presenting cells, digested, and then presented on the surface in the form of MHC, bounded to mutated or virus-related peptide in the case of HPV-driven cancers like cervical cancer. This MHC peptide complex then gets recognized by TCRs present on the surface of T cells, and T cells thus become activated and migrate to cancer sites where they can carry out anti-tumor activity. In this talk, I'll discuss different types of immune therapies that have been exploited for cancer therapy. We have a variety of molecules targeting surface receptors that are normally inhibitory. Collectively, these are known as immune checkpoint inhibitors, or such as pembrolizumab. We also have tumor-targeted antibodies or antibody-drug conjugates, or ADCs, which are not immunotherapy per se, but nevertheless target cancers with these drugs that can potentiate tumor lysis and thus recognition of the immune system. Lastly, we'll touch upon adoptive T-cell therapy. In this therapy, T cells from patients are obtained by leukapheresis, modified in a way to enhance the recognition of tumors, and then get injected back into the patients as treatment. Let's start with immune checkpoint inhibitors in the treatment of metastatic and recurrent cervical cancer. Keynote 158 was a study that resulted in the FDA approval of single-agent PD-1 inhibitor pembrolizumab in the treatment of advanced cervical cancer. In this phase 2 study, patients with cervical cancer previously treated with chemotherapy were treated with pembro 200 milligrams flat dose with every 3 weeks. An overall response rate of 14.3% was observed in patients with PD-L1 positivity. Notably, these responses were only observed in the patients whose tumors were positive for PD-L1 expression. None of the patients with PD-L1 negative tumors had responses, and this led to the FDA approval of pembrolizumab in the treatment of previously treated PD-L1 positive cervical cancer. The PD-L1 IHC companion diagnosis was also approved. Later in April 2020, Q6-week dosing of pembro was also approved. Still, we have data that PD-1 inhibition can be effective in PD-L1 negative cancers. Here is data presented by Dr. Tawari and others at ESMO 2021. In this phase 3 trial involving patients whose recurrent cervical cancer had progressed after first-line platinum-based chemo, single-agent therapy with PD-1 inhibitor cemiplimab significantly improved overall survival as compared with chemotherapy physician choice among patients with squamous cell carcinoma and in the overall population. In the overall population, cemiplimab reduced the hazard of death by 31% with a median survival of 12 versus 8.5 months. This survival was was observed irrespective of histology type and PD-L1 status. Based on this data, the FDA initially granted priority review of cemiplimab. However, this application was voluntarily withdrawn in October 2021. Discussions with external regulatory organizations beyond the US are in progress. The final single-agent PD-1 blockade in cervix I will touch upon is this phase 2 study of 138 patients with cervical cancer treated with balstilimab in second line. Here is the waterfall plot illustrating overall response rates of 13%, CR 2%, and PR 11%. Duration of response was 15.4%. PD-L1 was defined as CPS greater than 1, and responses were seen in both PD-L1 positive and negative patients. The FDA accepted the biologic license application for this drug. However, like cemiplimab, was voluntarily withdrawn in October 2021. So in summary, of the 3 anti-PD-1 antibodies in second-line cervical, pembro is the only one which has so far received full FDA approval since October 2021. Cemiplimab and balstilimab were both accepted for biologic license application in 2021, but applications were voluntarily withdrawn October 2021. So what I presented thus far is single-agent activity. How can we do better? A number of trials have explored combination of PD-1 and PD-L1 inhibitors with chemotherapy. And next, I'm going to talk about combination immune checkpoint blockade with chemotherapies. PD-1 are being combined with standard agents we use for locally advanced, top table, and the metastatic disease in the bottom table. Here are the randomized phase 3 trials evaluating combination of cisplatin chemoradiation with either durvalumab or pembrolizumab in locally advanced cervical cancer. The CALA trial is a phase 3 randomized trial in which patients were randomized 1-to-1 to receive either durvalumab or placebo every 4 weeks. All patients received external beam radiotherapy with platinum chemo for 5 weeks, followed by image-guided brachytherapy. Primary endpoint was PFS. In March 2022, just a few months ago, an updated readout of CALA did not demonstrate a statistical significance of durvalumab plus chemoradiation compared to chemoradiation alone. Ongoing is Keynote A18, investigating pembrolizumab versus placebo in combination with concurrent chemo-RT in the treatment of locally advanced cervical cancer, with primary endpoints of PFS and OS. The results of these trials, CALA and Keynote A18, have not yet been published and remains an area of high therapeutic need. For patients with newly diagnosed metastatic or recurrent disease, platinum combinations of taxanes and bevacizumab from GOG 240 were explored with pembrolizumab in Keynote A26. GOG 240 was explored with Keynote A26 and undergoing exploration with atezolizumab, BEAT-CC, and BCD100 in the Fermata trial. These are patients who have not yet received prior systemic chemotherapy. So let's focus on Keynote 826, given its FDA approval in October 2021, moving the field forward in the treatment of metastatic cervical cancer. Keynote 826 is a randomized, double-blinded phase 3 trial of chemotherapy for first-line treatment of recurrent, persistent, and metastatic cervical cancer. Eligible patients had no prior systemic chemo, prior radiotherapy, and chemoradiation was permitted. Patients were stratified based on metastatic status at diagnosis, tumor PD-L1 status, and planned bevacizumab use. Patients were randomized 1-to-1 to chemo plus pembro or placebo every 3 weeks, and the chemo regimen consisted of a taxane, cisplatin, or carboplatin with or without bevacizumab, and was selected by investigators pre-randomization. Treatment continued until disease progression, unacceptable toxicity, or voluntary patient withdrawal for up to 35 cycles or 2 years, and primary endpoints were PFS by RECIST or OS. Secondary endpoints were overall response, duration of response, and safety. For the first primary endpoint, PFS, addition of pembro to chemotherapy with or without bevacizumab led to a 35% reduction in the risk of disease progression in all comers. PFS or OS benefits of immunotherapy were observed irregardless of bevacizumab use and independent of PD-L1 status. 88% of patients had baseline PD-L1 CPS of greater than 1, and 51.4% had CPS greater than 10. In patients with PD-L1 greater than 1, median PFS was 10.4 months with pembro versus 8.2 months with placebo. For CPS greater than 10, the rates were almost identical, 10.4 and 8.1 months respectively. Similarly, in all comers and in enrolled patients, irregardless of PD-L1 status, a rate of median PFS were 10.4 months and 8.2 months. The between group subgroup differences were statistically significant across all subgroups, but not significant for the PD-L1 negative patients or age greater than 65. Given the small size of the subgroup of patients with PD-1 CPS less than 1, 11.2% of patients, it was not possible to draw clear inferences about the efficacy of the subgroup of patients with PD-L1 less than 1, but the effects, if any, remained small. This translated to OS outcomes. Addition of pembrolizumab to chemo with or without bevacizumab led to a 33% reduction in the risk of death. OS at 24 months was statistically significant in all comers, 50.4% with pembro and 40.4% with placebo. In the PD-L1 greater than 1, 53% in the pembro group and 41.7% with the placebo group. In CPS 1 to 10, 54.4% and 44.6% respectively. Median OS was not reached in patients in the pembro group with CPS greater than 1 or greater than 10. And in all enrolled patients, median overall survival was 24.4 months with pembro versus 16.5 with placebo. The pre-specified subgroup analysis showed a PFS and OS across all subgroups, again, given the small size of the subgroup of patients with PD-L1 negative, 11.2%. It was not possible to draw clear inferences about efficacy in the subgroup of patients with PD-L1 less than 1, but the effect, if any, remains small. Side effects of the combination therapy were manageable, and the observed adverse events were as expected based on previous data on individual drugs. The most common grade 3 to 4 adverse events were anemia, 30.3% pembro group and 26.9% in the placebo group, and the neutropenia, 12.4% and 9.7% respectively. In conclusion, the phase 3 trial incorporating PD-L1 blocking antibodies in combination with chemo plus or minus bevacizumab for metastatic disease provided clinically meaningful OS and PFS improvements in patients with recurrent and metastatic cervical cancer. So based on these results, October 13th, 2021, the FDA approved pembro in combination with chemo with or without bevacizumab for patients with persistent recurrent or metastatic cervical cancer whose tumor expressed PD-L1 CPS greater than 1 as determined by an FDA-approved test. And so we see how this is practice changing as we move forward with these incremental improvements in survival benefits in treating metastatic and recurrent cervical cancer with combinations and biomarkers. Tracing back to 2009's GOG 204 established a global standard with a backbone of platinum plus taxane for a median overall survival of 12.9 months. GOG 240, with the addition of bevacizumab in eligible patients, had a median overall survival of 17.5 months, and most recently, the addition of pembrolizumab in biomarker-positive patients. Keynote 826 showed median overall survival that had not yet been reached, but 24.4 months in all comers, moving the field forward and leading to its FDA approval. Next, let's talk about other immune checkpoint inhibitor combinations with immune therapies. First, Checkmate 358, which explored the combination of ipilimumab and nivolumab combined immune checkpoint blockade targeting CTLA-4 and PD-1, respectively. This study was conducted in patients with both newly diagnosed as well as patients previously treated with prior systemic treatment. And there were two different groups in the study exploring different dosing regimens of nivolumab and ipilimumab based really on the amount of each drug that was given. You can see that the overall response rate in all groups was higher than what we would expect with PD-1 alone. As a reminder, in Keynote 158, the pembro overall response rate was 14.3% in PD-L1 positive patients. Notably, the responses were particularly notable in the newly diagnosed patients who had received no or received no prior systemic treatment versus those who were newly diagnosed with prior systemic treatment, and these responses were durable. Looking at PFS, we can see that both dosing regimens of nivolumab and ipilimumab, the patients who had not received prior systemic therapy for their disease, had 52.6 and 43.5% 12-month PFS, respectively, with the two varying dosing regimens. In fact, many of them remain progression-free 2 years after initiation of treatment. This highlights the power and durability of this combination, PD-1 and CTLA-4 blockade in cervical cancer patients, particularly patients who had not yet received systemic chemo, and may suggest that immune therapy may also be effective in those who have not had prior exposure to systemic, potentially lymphodepleting therapy and disease. I'll next talk about recent approvals and ongoing clinical trials of antibody drug conjugates, or ADCs, in the treatment of cervical cancer. So tisotumab vedotin TV is an ADC directed at tissue factor covalently linked to microtubule disrupting agent MMAE, monomethyl auristatin, via protease cleavable linker. This therapeutic approach of ADCs relies on carrying a drug cytolytic cargo directly to the tumor with antibodies specifically targeting a tumor-associated antigen that may be present on the tumor cell. TF, or tissue factor, is highly prevalent in cervical cancer and other solid tumors. In such a case, the ADC is able to deliver this payload directly to the tumor cells, is internalized, and the payload gets released intracellularly where it mediates anti-tumor effect. The advantage of this strategy is the minimal toxicity to off-target distant sites, but also maximal potential toxicity to tumor cells. And thus, TV has multiple antibody effects, direct cytotoxicity, bystander killing, immunogenic cell death, as well as ADCC and ADCP. The phase 2 trial of tisotumab vedotin in recurrent or metastatic cervical cancer patients who had progressed during or after doublet platinum therapy. 101 patients were treated with TV, 2 mg per kg IV every 3 weeks, and treated until progression of disease or unacceptable toxicity. Primary endpoints were overall response rates, secondary endpoints, duration of response, time to response, and PFS by independent review committee, and safety. There were clinically meaningful and durable responses observed with TV in second-line cervical cancer. The study demonstrated an overall response rate of 24%, 7 patients with CRs, 17% with PRs, a disease control rate of 72%, and disease duration of response of 8.3 months. Notably, these responses were observed across all population and consistent across the pre-specified subgroups, including patients who had received more or fewer lines of prior therapy, radiation, or prior bevacizumab. Of note, treatment-related toxicities, specifically AEs of interest, included ocular, bleeding, and peripheral neuropathy. Ocular AEs were mostly mild or moderate, mostly resolving and manageable with an eye care plan of drops and eye compresses. Most bleeding events were grade 1 epistaxis in 28%, of which majority resolved. And finally, a known MMAE-related toxicity, peripheral neuropathy, was mostly grade 1, and though manageable with dose modifications, many did not resolve. This, however, was limited by the follow-up period of the clinical trial. Based on the positive data of ANOVA-TV 204 showing meaningful and clinically durable responses, the FDA granted accelerated approval of tisotumab in recurrent and metastatic cervical cancer in second-line as single agent. TV is now being moved to frontline and second and third-line settings in combination with chemo and immune checkpoint blockade. At ASCO 2022, Dr. LaRosa presented initial results of ANOVA-TV 205, the dose expansion phase, consisting of 3 arms: first-line TV plus pembro, second and third-line TV plus pembro, as well as first-line TV plus carboplatin. Here is a summary of the efficacy and safety of frontline TV in combination with carboplatin. 33% of patients, 33 patients were treated with this combination with a median of 6 cycles. Confirmed overall response rate was 55% with 12% CR and 42% PRs. Median duration of response was 8.3 months. With time to response 1.4 months, median PFS 9.5 months, median overall survival had not yet been reached. All patients had adverse events, with 76% reporting grade greater than 3, regardless of causality. And pre-specified AEs of interest included ocular toxicity, 3% with grade greater than 3, peripheral neuropathy, 12% with grade greater than 3, and bleeding events, 6% grade greater than 3. In the second and third line TV in combination with Pembro, results as updated at ASCO 2022. 35 patients were treated with second and third line TV plus Pembro with a median of treatment of 6 cycles. In the second and third line setting, overall response rate was 38% of this combination, observed with extended PFS of 5.6 months and OS of 15.3 months. Of note, 81% of these patients were PD-L1 positive, and here again, all treated patients had AEs, with 74% reporting grade greater than 3 AEs regardless of causality, ocular tox 3% grade greater than 3, peripheral neuropathy 3% greater than grade 3, and bleeding events. There were no treatment-related deaths in either or any of the cohorts. The combination frontline TV plus Pembro had overall response rates of 40.6 and CR 15.6. 97% had a PD-L1 positive disease, consistent and compelling reduction in target lesions across the treatment arms. This combination of TV and Pembro suggests the potential for TV to be incorporated in the combination with incorporated into the combination regimens to further improve clinical outcomes in frontline recurrent metastatic cervical cancer, and further research to evaluate TV combinations, for example, TV plus Carbo plus or minus Bev in the frontline recurrent metastatic setting, are ongoing. Finally, I wanted to talk briefly about adoptive T-cell therapies in the treatment of metastatic recurrent cervical cancers. T-cell therapies are based on T-cells being removed from the patient's tumors or peripheral blood, grown out and modified in the periphery or outside, and injected back into the patients as cancer treatment. Several different approaches using adoptive T-cell therapies have been explored in cervical cancer. The first approach, called TIL, tumor infiltrating lymphocyte therapy, involves resection of the patient's tumor, isolation of the TILs, expansion of the TILs in the periphery, and then injection back of the therapy back into the patient. The second approach involves sourcing of the peripheral blood mononuclear cells, or PBMCs, by leukapheresis, genetic modification of these T cells to express a T cell receptor recognizing a specific tumor antigen, and then injection of these cells back into the patient. And thirdly, T cells can be removed from the patient and then educated in the periphery to recognize specific antigens, and then again cloned, selected, sorted, and expanded and injected back into patients as treatment. Here's an example of the first approach, TIL therapy, which involves extraction of the patient's tumors, isolation of the TILs, expansion via interleukin-2, ex vivo in the periphery, and then infusion back into the patients after myeloablative lymphodepletion. Here is a smaller, earlier study presented by Dr. Amir Jazari at ASCO in 2019, demonstrating an impressive overall response rate with such a strategy. In this case, 44% of patients had some sort of tumor response, and these responses were durable, with 85% disease control rate, and at a median follow-up of 7.5 months, the median duration of response had still not yet been reached. Importantly, the clinical trial highlighted how this approach is feasible. So based on this data, in May 2019, the FDA granted breakthrough therapy designation to Iovance's TIL therapy, lifileucel, in recurrent metastatic or persistent cervical cancer with disease progression on or after chemo, based on clinical data from the ongoing INNOVATIL-04 trial. The pivotal cohort 1 enrolled in Q4 of 2020, and we await the results with much anticipation. So a summary of my talk showing the evolving landscape of systemic therapy in cervical cancer patients. In the last 5 years, since 2018, treatment of metastatic recurrent cervical cancer has rapidly evolved with the approval of immunotherapeutics like single-agent PD-1 inhibition, pembrolizumab, as well as the incorporation of pembrolizumab in the frontline setting with Keynote 826, as well as tisotumab in the second-line setting. Ongoing studies of IO therapies in combination with upfront concurrent chemoradiation is ongoing, as well as awaiting data readouts of adoptive T-cell therapies like lifileucel. My conclusions: pembro as second-line treatment of recurrent metastatic cervical and as frontline in the combination with chemo plus or minus Bev is an approved cervical cancer treatment for patients whose tumors express CPS greater than 1, but based on meaningful OS and PFS improvements demonstrated in Keynote 826. ADCs directed at tissue factor, tisotumab vedotin, TV, are approved as second line based on ANOVA TV trials. And lastly, early trials of TIL therapy and engineered TCR therapies confirm feasibility of such approaches and demonstrate deep and durable responses in a number of treated patients. And we have a lot to look forward to in this evolving landscape and management of recurrent cervical cancer. Thank you. I would like to thank you for the opportunity to speak about this important topic, and I'm happy to take any questions.
No, thank you so much.